Dr. May. I think we're a minute past the hour. We could probably go ahead and get rolling.
Okay, sounds great. Um, so I'll say hello and welcome to Unremarkable Labs. So the point here is that we go through cases with focus on evaluation, interpretation, and application of labs. And so I'm Jori May. I am a benign hematologist at UAB. I'm excited to be here. Thank you for the invitation, and I will be moderating or helping with today's session.
Great. We're glad to have you, Dr. May, for our first heme session. So I'm Stephen Alon. I'm one of the chiefs here at UAB, and I'll be helping with presenting the case. Sean Carter is another one of our chiefs. He'll be running the whiteboard, and Seema Kumar, another chief at UAB, will be moderating the chat. And I'd like for the two discussants to introduce themselves if they don't mind.
Hey, I'm Maddie Bender. Oh, sorry, I'll go.
Go ahead.
I'm Maddie Bender. I'm a PGY2 at UAB.
What's up, everybody? I'm Jacob Roman. I'm a intern at UAB.
Right, great. And so Sean is going to just briefly recap last week's session, and then we'll jump in.
Yeah, so last week we were fortunate enough to have a hyponatremia case. So just kind of the things to remember from that is to make sure you're dealing with the true hypotonic hyponatremia, and then evaluate volume status and check your urine osms to see if you have a solute intake problem or you have too much ADH activity. So with that, I think Stephen, if you could start us off with the case.
Yeah. So today we've got a bit of a different case than our previous sessions. We've got a 45-year-old man who's coming in with fatigue and abdominal pain that radiates to his lower back. Been going on for a few weeks now. You have a CBC that was ordered done in the ED that showed a white count of 8.9, a hemoglobin of 7.4, a crit of 23, and a platelet of 259. That's all that you get to start with. And Jacob and Maddie, I'll leave it to you to kind of give us your thoughts.
All right, perfect. So I guess my first thought when I see this, because I'm naturally studying for step 3 right now, is seeing a male with it looks like an anemia pretty marked right now, and then the abdominal pain. The first thing that jumps out in my mind is this colon cancer. But then I guess another thing that jumps out to me is he doesn't have really like a pancytopenic. His platelets and his white count are normal. And then he seems kind of young to have colon cancer, although he could. So I guess this kind of leads me to, I really want to know more of a sequential history at this point to lead my thinking.
Yeah, I agree. The first thing that sort of jumps out to me is the low H&H, seeing that he's not pancytopenic. And when I see a low H&H, one of the things you wonder is he symptomatic from it? And reading that he has fatigue at least sort of keys me into that he probably is symptomatic from this anemia. And I agree with you, kind of getting more of a time course of how long this has been going on, what's led to it, and some more symptoms.
Yeah, I think those are both great points. I think, you touched on the big thing that I think about when I first look at a CBC is assessing all the counts. So anemia is very different from pancytopenia, right? So we have a clear isolated anemia, which you guys pointed out, which I think is important. And Jacob, you're jumping to the conclusion that this patient has been having chronic GI blood loss causing iron deficiency, which causes anemia, which can certainly be a very common presentation for colon cancer. We are seeing a lot more colon cancer in younger patients now, actually. That's something that's, we don't understand the trend and we don't really understand why, but it is something that we unfortunately are seeing more colon cancer in young patients. So that certainly makes sense on the differential. But just thinking more broadly, I think obviously time course is a big thing here, right? So if you're thinking about a chronic GI bleed, this is something that's been going on for a long period of time. So you wonder kind of the chronicity versus, is this all of a sudden he had sharp abdominal pain and is acutely having a large amount of blood loss that is causing this degree of anemia? So I think, time is, of the essence here, I think is really important.
Yeah, so I think everyone is kind of zeroing in. They want more historical information. I think that's great. So I'll let each of our discussants ask 2 questions from the history. You only get 2, so you got to pick them right. What do you want to know? Jacob, we'll start with you, and then Maddie will get your input as well.
As far as history goes, can you tell me how long this has been going on? Was this kind of an acute thing? Are there any other symptoms other than just fatigue?
Yeah, so this has been going on for about 2 to 3 weeks. He does not yield any other specific symptoms when you talk with him. And then Maddie, what would you like to know?
So specifically, I think things I want to tease out, and maybe by you saying he's not having something more specific, you're asking this, but asking him if he's had any dark, sticky stools as opposed to any frank, bloody stools that he might be having. I think some people don't realize that could be blood in their urine, anything sort of melanic looking. And then I think other symptoms like, is he having weight loss, other signs of malignancy that would point me to that.
Yeah. So first question with respect to his stool, he's passing normal brown stool, has not noticed any blood ever in there, no black tarry stools in the past. And I'm sorry, the second part that you were asking, Maddie?
Like symptoms associated with malignancy, any weight loss. He did talk about fatigue, fevers, night sweats, that sort of thing.
Gotcha. So no B symptoms, no fever, no night sweats, no weight changes.
So I guess that's helpful information, right? So unfortunately, our initial jump was that we were thinking, this is GI blood loss. It doesn't seem like it's necessarily lining up that way. We haven't necessarily excluded it yet. But when I approach an anemic patient, I think there's kind of a general branch point of, if we're saying that this is an acute process, if his hemoglobin was potentially normal a couple of weeks ago, and then all of a sudden something happened and he's feeling bad, like blood can only go 2 places, right? He's either bleeding or he's consuming it. So hemolysis would be the other concern in a patient like this. There's other ways that you can lose blood as well, right? It's not just in the GI tract. So hematuria is a concern. You can actually hold a large amount of blood in the retroperitoneum or bleeds into the thigh. So just because he's not losing blood in his GI tract doesn't mean that there's not bleeding going on somewhere else that could acutely cause a change in hemoglobin. But at the same time, also thinking about starting to ask questions and think about that differential for what would cause hemolysis, and maybe what could be triggering that in this patient would certainly be a concern.
Yeah, I think that's really great points. So just to help with the different little bit, I've got a couple additional labs from the CBC that I'll share, and I'd love to hear everyone's input. So with respect to his CBC, his MCV is 86 and his RDW is 19.
So I guess it's a good question maybe for Jacob and Maddie to talk about it. So when you have an anemic patient coming in, kind of what is the first laboratory approach? So, Stephen already gave us some of the red cell indices, and we can talk about those. But how do you think about anemia, and kind of what is your usual diagnostic approach, if you have one, and maybe you don't?
I think easily, quickly, usually comes with our red blood cell indices. So I'm looking at the MCV. Is this macrocytic? Is this microcytic? That immediately sort of gets me down 2 different pathways. And then also looking back, if we have any old CBCs on file, is this more acute? Is it chronic? Do we have a slow downtrend through time? Or a couple weeks ago, were they completely normal and now they've dropped?
Yeah, I think that's great. Chronicity is important. Looking for old labs is a game changer. If you have access to that in your medical record, that's huge. But yes, that's helpful. Jacob, anything else that you think about?
That's where I would start, as like more of a morphologic approach to how I break down anemia. I've read other ways that people do it by more of overproduction or underproduction anemias, like looking at reticulocyte index. So I guess apart from that, that would be where I would go next after the morphology.
Yeah, so that's a great point. You kind of touch on, there's different paradigms for how you can approach an anemic patient, and everybody has their favorite. I will say I am biased towards the reticulocyte approach, and I'll try to sell you on it because that's just what I'm going to do. But so you're right. So the red cell indices are there. They're already part of the CBC. So certainly that helps with your differential. But I find that the reticulocyte count is actually usually my first go-to in a patient. And the reason for that is that it helps me know what the bone marrow is doing, right? So if you have a reticulocyte count, so to remember how we report a reticulocyte count in the computer, every electronic medical record is going to be different. There's usually a percentage, there's also an absolute count. But what's important is that you think about the reticulocyte count in the context of the patient's degree of anemia, right? So if I have a reticulocyte count of 3% and my hemoglobin is 12, that's probably appropriate, maybe even a little bit high. Whereas if I have a reticulocyte count of 3% and I have a hemoglobin of 7, that's probably an inappropriately low response. So that's what the reticulocyte index gives you, which you made reference to, which is a calculation that basically takes into account the hematocrit as well as maturation factor. So for how rapidly reticulocytes mature. And it basically gives you framework of, is this an appropriate reticulocyte response? So is your bone marrow responding appropriately to the degree of anemia, or is it not responding appropriately? And I think that's a really helpful tool. So the usual cutoff for a reticulocyte index that's appropriate is usually greater than 2. You can just Google MedCalc and type in those numbers to get your reticulocyte count. So I do think that would be helpful. But then you talk about too, so the other way to approach this is starting with red cell indices, right? They're built into your CBC. It's already right there. And those are certainly helpful. So that MCV, we're referring to the mean corpuscular volume. So it's basically how big your red cells are. I think the important thing to remember about the red cell indices is basically they are quantifications of what the blood looks like under the microscope. So you can get that same information from going to look at a peripheral smear, but this is just kind of a quick, fast way to take a look up. So actually it's trying to tell you numerically what visually the red cells look like. So a low MCV is really small red cells, a high MCV is bigger red cells, normal MCV is around the normal size. The differential is obviously different for those, and we can talk a little bit about that. I find that that's helpful, but I also think that a lot of patients don't read the textbook. And so some of these numbers can be a little bit misleading in clinical practice, but I think it's certainly helpful to start your differential, particularly if you have microcytosis or macrocytosis. Normocytic anemia can kind of be a little bit of everything, so it's a little bit harder. And so in this patient already, we're kind of in the middle, and we don't have an easy clue necessarily that the patient is really microcytic. So iron deficiency and thalassemia are really high on my list versus a really high MCV where I'm thinking about megaloblastic causes. So that's kind of my general framework for at least my first approach to an anemic patient. So, yeah. Oh, go ahead, Stephen.
Well, I don't want to give labs away if you had more to add.
No, I think that's it. Well, I guess you threw up the RDW, so we should probably talk a little bit about that. So do y'all know, familiar with the RDW? Do you use that often? Anybody?
I think you can use it a little, especially in pictures of like a normocytic anemia. It could be pointing us to this is maybe something mixed. A mix, it being high, this could be a mixed microcytic and macrocytic anemia. Those are really the only times that I use it.
Yeah, no, that's perfect. I mean, so you get to the main point there, which is it's telling you the mix of sizes of red cells, right? So the RDW is the red cell distribution width. And so I never really understood what that number was, but it's actually a measure of, if you were to plot out, I'll draw with my hands, but on the x-axis, if you have the corpuscular volume of every red cell, right? So, little red cells over here, big red cells over here, and you have a bell curve of the size of your red cells in your sample. So a high RDW is actually a measure of a wider bell curve, right? So it's the width of the bell curve, meaning so there's a lot of, there's a variation in smaller cells and larger cells. Whereas a normal RDW is a really narrow bell curve, meaning all your red cells are about the same size. So Maddie, you're exactly right. It's helpful when you're thinking about different populations of cells. An example is in microcytic anemia, so iron deficiency anemia. You have a lot of variation in the size of those red cells. So it's a microcytic anemia with a high RDW, whereas in thalassemia, all those cells are about the same. They have the same hemoglobin content, and so their RDW is normal in the microcytic anemia. So it helps a little bit with some of those. And here we interestingly have a high RDW. There's a couple of things to think about. And one thing that particularly in a patient where I might be concerned about bleeding and the RTW is high, is to remember that reticulocytes are actually really big cells. So if you have a patient that has anemia for some reason, has bleeding for some reason, they become acutely anemic, their bone marrow is starting to respond appropriately. You have normal sized red cells, and all of a sudden you have these like big Goomba reticulocytes that are going to actually spread your RDW. So again, another reason to argue for my favorite lab, the reticulocyte count, to give us some more information.
So Dr. May, I think you're telling me really desperately that you want that retic count. So
I do.
so we will give you that first piece of information. So his retic count is 8.3%.
Okay. So what do you guys think of that?
That seems more appropriate given the hemoglobin of 7. So it seems like the bone marrow is responding. So I guess that directs me more to, is this hemolysis or some other like consumptive type process?
Absolutely. So I'm going on MedCalc right now to calculate the reticulocyte index because that's what I told you to do. So I should follow my own instruction. So if it's 8.3%, we said the hematocrit in this patient was 23. And it says, a normal hematocrit in MedCalc estimates is around 42, which is fine. So our reticulocyte index is 2.27, which is above 2. So you're exactly right. The bone marrow is doing what it's trying to do. It's keeping up. It's trying to keep up as fast as it can, but this patient is losing blood one way or the other. Like we said, there's only 2 places blood can go. He's either bleeding it or he's consuming it. So I think you're exactly on the right track.
Dr. May, you mentioned when talking about the MD Calc that, they put in the normal value, the hematocrit value. So that brings up a couple questions that were in the chat that just kind of on a side note about what is normal hemoglobin anyway, based on anyways. And, we have parameters for men and women, and where are those numbers coming from?
Yeah, so that's a great question. And so important to note that, yes, that's exactly right. In general, men do tend to have a baseline higher hemoglobin and hematocrit than women do. But a lot of that's probably related to testosterone production that tends to lead to a higher hematocrit. A lot of those values are defined by your laboratory. So there's a lot of variation that within your laboratory, you're going to have an internal validation process to determine what the normal range is. You can certainly always Google and find that. But to remember that normal ranges are kind of old historical creations of, they tested a lot of patients and defined a normal range. One good example of where a normal range can kind of fail you is actually in the neutrophil count. So if you've ever heard of benign ethnic neutropenia, so basically we know that African American patients actually tend to have a lower ANC than Caucasian patients. And so the normal range was defined by Caucasian patients. And so all of a sudden, a lot of African American patients have a lower ANC. They get referred to us in hematology about concern for that. But really, it's just that within that racial population, what is normal is a little bit different. So, in hematocrit, I'm not familiar with, any sort of significant variations in the normal range for any specific populations, but it really tends to vary with your lab. So certainly important to keep that in mind.
So now that we've got a gentleman who we know has an acute anemia that's normocytic with an elevated RDW and an appropriate reticulocyte index, what do you guys want next? Jacob and Maddie, what would you like? Any additional labs or history? Where are you going from here?
I guess 2 things. One would be, can I get a physical exam? Is the guy jaundice, scleral icterus, bleeding anywhere? And then 2, I guess LDH, haptoglobin, LFTs, to see if he's hemolyzing.
Okay. Yeah, so I'll give you those, and then I'll let Maddie chime in as well. So you want a physical exam. So he does have maybe some mild scleral icterus, but otherwise he appears quite comfortable. He does not, his belly is soft. He doesn't have any frank ecchymoses anywhere. And then you wanted specifically an LDH, a haptoglobin, and LFTs. Is that right?
Yes.
Okay, so the haptoglobin is less than 30 with an LDH of 607. As far as LFTs, his total bili is 4.1 with a direct component of 1.0, AST is 17, ALT is 15, and alk phos is 83. And then albumin is 3.7.
Okay. So, Jacob, and you ordered all the right labs that I would order initially if I wanted to confirm that a patient was hemolyzing, but I think it's important just to kind of pause and talk about those. So, LDH you ordered, which is really what I think of as like a non-specific marker of cell turnover. There's a lot of things that can make an LDH go up. Hemolysis is certainly one of them. Acute illness, anything that's caused rapid turnover in cells. So it's non-specific, but it's helpful. Haptoglobin is what binds free hemoglobin in circulation. So if you're hemolyzing, you're releasing hemoglobin, your haptoglobin disappears from circulation, it binds up, and so it's therefore becomes low. I would say haptoglobin is a really sensitive marker of hemolysis. So it only takes a little bit of hemolysis for your haptoglobin to drop. So I do find that to be a really helpful test. If I want to exclude hemolysis and I have a normal haptoglobin, I feel pretty confident that the patient isn't hemolyzing because it really is a sensitive marker. And then you wanted to see the bilirubin. We're thinking about indirect hyperbilirubinemia in these patients, right? This unconjugated bilirubin that isn't processed by the liver that goes up in the setting of hemolysis. And that's certainly what we see here. So all of that is certainly important. And when you think about, scleral icterus, in general, I always think of the rule of a bilirubin over 2 or so is when you should start to see things. I mean, in my diagnostic skills, it might be closer to 3 or 4 before I'm able to detect it. But just to give you an idea of how the labs correlate with what you see on physical exam. So you can have some low-level hemolysis without necessarily seeing a physical exam change.
Dr. May, for haptoglobin, do you have any feeling about it ordering it for cirrhotics? And does it make a difference as far as extravascular or intravascular hemolysis and the utility of it in those situations?
Yeah, so that's a great question and a great point. So you're right. So haptoglobin is made by the liver, as are a lot of the proteins in our body. So in a cirrhotic patient, the baseline haptoglobin might be lower or may be undetectable. So detecting hemolysis in cirrhotic patients can be a lot more complicated, and that's a really good point. So intravascular and extravascular hemolysis, again, I often find in clinical practice, there's a lot of overlap between those two. It's something that we learn in medical school, it's very, intravascular, extravascular, but a lot of times, particularly if you're having robust hemolysis, you're gonna have spillover of hemoglobin into one space or the other. In general, if I'm worried about intravascular hemolysis, I actually find checking a free hemoglobin to be very helpful. More, again, the haptoglobin is so sensitive, it can kind of drop in either scenario. But if you're seeing circulating free hemoglobin, it definitely raises your concern for causes of intravascular hemolysis. So you could incorporate that lab check as well.
All right, great. So we've got part of the picture from Jacob. Maddie, are there any additional labs that you would like?
I think usually when I'm thinking, so this all sort of pointed us down the route of hemolysis, and so usually when I consult heme at this point, they tell me to get a Coombs test. And so that's the thought that I would have for him. And then history-wise, also, I'd want to ask him if he's had any recent illnesses, respiratory, GI bugs, that sort of thing.
Yeah, so that's great. So heme did tell us to get a Coombs test. So his direct antibody test was positive for C3. And as far as recent illnesses, no, he has not had any respiratory or GI illnesses recently.
Maddie, I'm very happy with your response. You have been well trained by our consult service, which is great. And so I think, important to talk a little bit about what a Coombs test is, and really in general. So, let's take a step back and talk about hemolysis. If you do call the consult team, what are we looking for in these patients? And it's a couple of things. The Coombs test is part of it. Peripheral smear is certainly part of it too. So we oftentimes will go look at that, but certainly anybody can go look at a peripheral smear, but that's a really helpful and important piece, and we'll get to why that is in a little bit. But I guess talk about the Coombs test first. So Maddie, I don't mean to put you on the spot, but do you remember what the Coombs test tells you? So it's C3 positive. What are you looking for? What does the Coombs test do? Any ideas?
Not particularly. I know that it points us down the rabbit hole of this is possibly an autoimmune hemolytic anemia.
That's it. You're exactly right. And that's what I was looking for you to hopefully say, is that what you should know. So when we think about, right, go back to your med school days of the Coombs, the direct Coombs and the indirect Coombs, okay, or the direct immunoglobulin test. And so the way I remember those is, so basically the direct Coombs is looking for, basically you're taking red cells from the patient and you're adding an anti-immunoglobulin. So you're looking for immunoglobulins that are actually bound to the surface of the red cell. And so if they're present, the immunoglobulin that you add causes agglutination, and it's a positive test. Okay. The indirect Coombs is something that our colleagues in OBGYN are using, looking for the presence of antibodies in plasma. So you're taking patient plasma and looking for antibodies. So you actually add donor red cells to that in order to measure for agglutination. So as a hematologist in internal medicine, I'm rarely ordering an indirect Coombs. What I need is a direct Coombs. I want to see if there are antibodies bound to the surface of the red cell that's causing an autoimmune hemolytic anemia. And so that's exactly what this test is for and what it's telling us. So it might be worth mentioning, so on peripheral smear, if you have an autoimmune hemolytic anemia, any ideas what you would see? To Maddie or Jacob or anybody else?
Would you see schistocytes?
So that's a good question. And that's certainly one of the reasons we get a
would.
peripheral smear. Yeah. So the answer is no, but you're exactly right. So again, getting to why the peripheral smear is important in hemolytic anemias is because there's a lot of things that can cause a hemolytic anemia. So there's, you know, hereditary causes that I think about. So things like sickle cell disease, thalassemia, less likely in this patient, right? This is a new acute process. But in the acquired causes, one of the things that you're talking about, Jacob, is we're thinking about thrombotic microangiopathies, right? Those disorders that cause microvascular thrombosis. And when a red cell goes by that microvascular thrombosis, you get this schistocyte form as the red cell breaks up. So that's TTP, atypical HUS, DIC can all cause something like that. So important to look for on the peripheral smear, but not necessarily something we would see in an autoimmune hemolytic anemia. But I think I've seen some rumblings of spherocytes. And so that's actually something I would expect to see on peripheral smear in an autoimmune hemolytic anemia. So spherocytes are those really teeny tiny cells. So basically what happens is, you know, when your red cell is healthy, it has this nice biconcave disc shape, right? So there's enough membrane that allows the red cell to make this nice shape so that it can morph and travel through circulation without problem. But what happens in autoimmune hemolytic anemia is basically you get this binding of the immunoglobulins to the surface of the red cells. They get stuck in the spleen, and macrophages in the spleen kind of take little pieces of the membrane as they try and remove those antibodies. And so the cell slowly forms into this more spherocyte shape, which can't deform through circulation and ultimately hemolyzes. So all this to say, I bet if we looked at the peripheral smear on this patient, probably would have some spherocytes.
So it sounds like we want a peripheral smear. So we got so on the smear, they saw nucleated RBCs with polychromasia, and I'm going to ruin this word, I'm sorry, anisocytosis and spherocytes.
Perfect. So anisocytosis is a fancy name for variation in the size of the red cells, which is a fancy name for an elevated RDW, right? We said we would see in our indices what we saw on our peripheral smear. So anisocytosis is the descriptive term for a high RDW, which is what they saw. Nucleated red blood cells just means that, again, the bone marrow is pumping out new cells as fast as it can. So these premature cells are entering circulation just like the reticulocytes are. So bone marrow is really doing its job here. And again, yeah, we see those spherocytes. So I am further convinced this is an autoimmune hemolytic anemia. And so interpreting DAT is not something I was able to do before my HemOnc fellowship, and I wouldn't expect you guys to be able to do. But in general, what you're looking for is, when we talk about a DAT, we're looking for, there's two things that we're testing for. So complement on the surface of the red cell and immunoglobulins on the surface of the red cell. So usually you'll see the report, you're looking for C3 positivity and or IgG positivity. And you also ultimately are looking for the temperature of binding, so whether it's warm or cold. And without going into too much detail, because this does not need to be a long discussion of autoimmune hemolytic anemia, positive C3 usually means there's complement activation on the red cell, and it's presumably IgG negative, which usually means that it's actually an IgM antibody that's causing it, which is more commonly associated with a cold autoimmune hemolytic anemia or cold agglutinin disease. there's more testing that would need to be done to do that, but that would certainly be my concern at this point based on the C3 positivity on the DAT.
All right, great. So I think at this point we all feel pretty confident that he's having a hemolytic anemia, and I think as everyone is sort of alluding to, the next question is why? And so we'll switch it up, and Maddie, I'll let you give your thoughts first about what you might want to pursue to answer that question.
I know one of the things we typically think about is, especially cold agglutinin, probably from Sketchy, triggers me for had a mycoplasma infection. And so that's something that I think about a lot. We could look for something like that, although he wasn't really symptomatic from any recent illnesses. Other than that, my understanding with autoimmune diseases is that they tend to correlate together. So I would probably do just kind of a basic rheumatic workup, ask him if he's having joint pains, type of rheum symptoms, and then we could get things like an ANA, rheumatoid factor, anti-CCP, all those things.
Yeah, so I can say he was not having any hair loss, no joint pain, no oral ulcers, no other rheumatologic symptoms. And so that would answer, I think, all of your questions. But absolutely one of the paths to go down. Jacob, and any other path that you would want to pursue?
Another thing I think I've heard with cold agglutinins is like B-cell lymphomas, however, he doesn't have B symptoms, and then maybe a multiple myeloma, and then we don't have like a BMP to look at his calcium or if he reported any bone pain or any x-rays, anything like that. So maybe we could get a BMP.
Yeah. So his BMP, I don't have the exact numbers, but everything was essentially within normal limits, which I know Dr. Center is going to get mad at me for saying. But they were truly unremarkable labs in that perspective. I know you're crying. I'm sorry. So I can tell you guys what, and then you mentioned lymphoma as well. So I can tell you guys when he was in the emergency department, because he was complaining of abdominal pain, they did get a CT of his abdomen and pelvis with contrast. And what they noted was a left adrenal mass versus a hematoma with no active extravasation, as well as periaortic and retroperitoneal lymphadenopathy. So given those CT findings, Maddie, what does that make you think about?
Yeah, with the lymphadenopathy and this mass versus hematoma, I'm more worried that there's some sort of undiagnosed malignancy going on overall.
Absolutely. Jacob, any thoughts about malignancy? What do you think about the possible hematoma?
I'm a little stumped with that, to be honest.
Yeah, we were too. Dr. May, maybe you could give us some insight.
Yeah, so I'm not sure if I have an easy answer, but so bleeding into the adrenal glands can happen for a variety of different reasons. You can actually have a thrombus there that leads to subsequent bleeding, or you can have kind of a primary hemorrhage within the adrenal gland, which is related, you always think about kind of a variety of different things associated with pregnancy. Certain infections can cause adrenal hemorrhage. I'm trying to make the connection with the potential autoimmune hemolytic anemia, and I'm sure there's something there that I'm missing. But certainly would make sure to look that up and look up that association of, is there something that helps tie those two together? Because that certainly is an interesting and unexpected finding in someone that, not explained by the hemolytic anemia that we're otherwise observing.
Yeah, and Maddie, to your point, the hematologists were also concerned about the lymphadenopathy, and it was really leading them down more of the malignancy route and less likely a hematoma. So what they did is they got a biopsy of that, of one of the retroperitoneal lymph nodes. And what they found was diffuse large B-cell lymphoma. And I don't know exactly what this means, but I hope Dr. May can explain. It was a non-GCB subtype that was CD20 negative.
Yeah, so Maddie, you were spot on. So you're exactly right. Lymphomas are associated with all sorts of autoimmune conditions, and autoimmune hemolytic anemia, and particularly cold agglutinin disease, can certainly be part of that. So when we think about diffuse large B-cell lymphoma, when I think about lymphomas in general, there's kind of the indolent lymphomas, things like follicular lymphoma that's slow growing, the more aggressive lymphomas, and then the highly aggressive. Highly aggressive is like Burkitt's lymphoma. Diffuse large B-cell lymphoma is kind of in this middle category. And as we've learned more about diffuse large B-cell lymphoma, we actually realize that within that category, there's a lot of variation. And so this division into GCB and non-GCB type is something that's relatively new, probably during my fellowship, but gives us some idea of how we treat these patients, which, is steps down the road. The important thing here is that this patient is, when we're thinking about treatment, is CD20 negative. So there's a drug that we use all the time in treatment for lymphoma that's very dependent on CD20. That's rituximab. So this patient obviously is CD20 negative. We won't have that tool in our toolbox, which is unfortunate because often that's very helpful. But he will have treatment options. And so I guess, important to think about kind of how you would approach this patient kind of acutely and then in the long term for treatment. So, what do you do with a patient who has this hemolytic anemia? How do you get it under control? And if you guys have any thoughts on that. And that's okay, because you should call a consult anyway. But the idea here is that the hemolytic anemia should improve with treatment of the underlying disorder. So, Maddie, your idea, you got to find out what's going on. You got to find that lymphoma. You got to get that biopsy, because ultimately anything that I do in the meantime to try and control the hemolysis is really just a Band-Aid. And oftentimes it's really difficult to control if it is mediated by an underlying malignancy. So really treatment of the malignancy is what's needed for treatment of the hemolysis.
Yeah, and so that's what they did. They started him on a regimen called DHAP, which Dr. May, I'm sure, can tell us about in a second. So in his, on further review of his history, he actually told us that he had a cancer a couple years prior. He couldn't really give additional details beyond it, but in talking with his family, it sounds like he had some form of lymphoma, presumably the same DLBCL that had recurred on presentation. So he was started on DHAP, and his hemolysis initially improved and he was able to be discharged. But unfortunately, he returned a month later and his hemolysis had worsened and his disease had progressed despite treatment. And he ultimately was discharged home on hospice.
Yeah, that's tough to hear. When we think of diffuse large B-cell lymphoma, it does tend to be a curable malignancy. We'd usually say in about 60%, but the non-GCB type is associated with a more difficult treatment course. So it's not surprising. And I think kind of, unfortunately, this is what we do see in patients who do have a malignancy related condition, whether, paraneoplastic, whatever we want to call it, is that often that can be the first sign of a relapse of disease, is that, the initial presentation for him was hemolysis, and when they relapse with hemolysis. So those symptoms can certainly come back.
And one thing I wanted to point out, Dhruv in the chat had mentioned what DHAP stands for, which is dexamethasone, high dose cytarabine, and cisplatin.
Yeah, I would. So if you're looking and want to know more about different treatment for different types of lymphomas, the NCCN guidelines are always the place to go. You have to create a free account, but it'll give you an algorithm for how all oncologists make those decisions. That's really a second line treatment. So when we think about treatment for diffuse large B-cell lymphoma, you might have heard of CHOP, right? So I'm wondering if maybe he had gotten CHOP in the past, and maybe that's why we went with DHAP for this gentleman. But some nuances there that I think are beyond the scope of what we need to do here. But important to know that, if you ever have questions about different regimens, those NCCN guidelines are a fantastic resource to just how oncologists are making those decisions. It's really helpful.
Well, thank you guys for helping us walk through this case. We started with someone with abdominal pain and anemia, and we somehow arrived at DLBCL, and you guys made that happen. So I'm going to let Lindsay, one of our rising chiefs, kind of give us a review of the learning points from this case.
Everybody, I'm Lindsay Shipley. I know most of you here tonight. Thank you so much, Jori, for coming tonight. Whenever she has a lecture, I always make a point to make extra effort to try to get there because I know it's also always going to be excellent. So thank you. And thanks, Stephen, for this case. I have just a couple teaching points for tonight. So in the beginning, Jori reminded us that whenever you see a CBC, it's really important to assess all counts because if you just had an isolated anemia like we did in this case, it would take you down a much different differential as opposed to if you had like a pancytopenia. So when you see an anemia, think about 3 different mechanisms. First is bleeding, second is consumption, or third is production. So bleeding, you think about not only the GI tract, but the thigh, the retroperitoneal space, and then even hematuria. Consumption processes, think of hemolysis, and then production, get the reticulocyte count and see what the bone marrow is doing. It is very good a way to figure out if it's an appropriate response or an inappropriate response. So maybe Jori has convinced you to jump to the reticulocyte index as one of your first workups for anemia. And then when we talked about the RDW, it really is a measure of a wide bell curve, so the variation in size. So think about that when you have a microcytic anemia and you have a number of reticulocytes, you may have a large RDW in those cases. And then so we talked about haptoglobin. It's made by the liver, so it will be lower in those patients with cirrhosis. So don't let that throw you off that you could have a hemolytic process in those patients. A good way to figure out if you're having an intravascular hemolysis is to look at a low free hemoglobin. So be sure to check that. So in our patient that had a C3 positive Coombs test, which made us think about some kind of direct autoimmune hemolytic anemia, which specifically looks at the immunoglobulins that are bound to the surface of RBCs. There's also an indirect type, which is primarily used by our OBGYN colleagues, which looks at antibodies in the plasma. So when you're thinking about a smear, autoimmune hemolytic anemia, think of spherocytes. If you see schistocytes, more likely TTP, atypical HUS, and DIC. And then when you're looking at the DAT, you're looking at complement, you're looking at IgG positivity, and then you're looking at the temperature of binding. And the thing that clued us into the cold agglutinin here was the C3 and the IgG negative. And causes, Maddie brought up a great cause, mycoplasma and also malignancy, and our patient ultimately ended up having a lymphoma. Thank you all for listening.
Thanks for that great review, Lindsay. So I just want to say thank you to everyone who participated in this case. Jacob and Maddie, it's not easy to be in the lukewarm seat. We appreciate y'all being willing to participate and sharing your thoughts. You did great. Of course, thank you, Dr. May, for going through everything and giving us a hematologist perspective. And shout out to our co-chiefs for helping run this, and to all the participants the chat's on fire. People are wanting the transcript, so we'll make sure to share that.
Can I ask Jori a question?
Sure.
So, not seeing a lot of autoimmune hemolytic anemia, I had never thought until tonight that it was associated at times with lymphoma. Is it when we see an autoimmune hemolytic anemia, should we think malignancy, or is that unusual?
I think it should certainly be in consideration. So you should always try and find a cause. Many times it's just going to be idiopathic and there's nothing there, but it happens. It's rare, but it's not exceedingly rare, and it's certainly worth considering.
Great, thanks.
Yeah.
All right. Well, thanks everyone for coming. We really appreciate it. And we'll upload this later in the week, and we'll see y'all next week, next Tuesday.
Thanks, everybody.
Thanks.